Welcome to the AUANews Inside Tract podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Welcome to Capital Stream, a special edition of the AUANews Inside Tract podcast series. I'm Josh Webster, Director of Public Policy and Advocacy at the AUA.
And I'm Dr. Mark Edney, Chair of the AUA's Public Policy Council. This episode is all about turning up the heat on health policy, recapping the AUA's policy efforts and advocacy efforts in 2025, and talking about looking ahead, what's next, and what AUA members can do to stay engaged.
From Medicare payment reform to telehealth access, we've been working hard to ensure urologists and their patients are heard up on Capitol Hill, as well as in the state legislatures across the country.
So let's dive in. Let's see what we've accomplished, what lies ahead, and what you can do.
Dr. Edney, let's start with the big picture. What were the most significant wins for the AUA in federal advocacy this year?
So we have several highlights to review, starting first and foremost with the appointment of Dr. Brian Christine, a fellow urologist from Alabama with a specialty interest in men's health, being appointed to the Assistant Secretary of Health and Human Services. That's the number 2 in command at HHS. And he's the highest ranking physician at Health and Human Services. And he's one of us. And so that's a huge win for Dr. Christine, for the House of Urology. The AUA was instrumental along the way during his confirmation process. We worked with the Senate Help Committee, helping them prepare for the hearing, providing some potential questions that they could ask him. So we've been very supportive along the way, and we're very proud of him and really look forward to a fruitful relationship with him. So stay tuned. We've already been in discussion with Dr. Christine about several initiatives that may be of common interest with the House of Urology and Health and Human Services. So I'm not going to forecast any of those right now, but stay tuned. There are likely to be some newsworthy announcements going forward this year as this relationship flourishes and we're able to get some work done together. Next is the FDA decision to remove the black box warning for low-dose estrogen. There have been a lot of AUA members working very hard on this issue, led first and foremost by Dr. Rachel Rubin, who's done a tremendous amount of work in advocacy. There's lots of others who've been involved, and if I start naming names, I'll leave people out. Dr. Rubin has been very prominent. And the issue has been, and urologists who treat this condition know this, the data to support that black box is either nil or non-existent. In fact, there's increasingly great data to show that especially topical vaginal estrogen is safe for women. And so we were able to share our genitourinary symptom guideline for genitourinary symptoms and menopause, and really assist the AUA, the FDA. We submitted comment letters, testimony, and ultimately we were very pleased to see the removal of that black box warning. We were even invited to the FDA's press conference for that. So that was a huge advocacy win for the AUA. Moving on, NIH funding for fiscal 2026 has been in the news. It's been front of mind, especially for our researchers in urology. When this administration took over, one of the initial budget provisions was to slash NIH funding by about 40%. And that created a chill across the research community, of course. Fortunately, through a lot of hard work on behalf of the AUA advocacy team, as well as coalition partners, the appropriators in Congress have come to see that as not a very good idea. And have started to work with us to really not implement that 40% cut. We've been to dozens of Hill meetings, sign-on letters. There have been congressional testimony and statements for the record submitted. Congress is still working on it, but we're happy to report thus far in the process, it appears that the NIH funding for fiscal 26 may actually increase a little bit. The process is far from over. We continue to work very hard on it. But it looks like we are poised to avert a 40% cut. So that's great. So turning back to you, Josh, Medicare payment reform has been a top priority. Can you walk us through where things stand and what permanent reforms we're still pushing for?
Yeah. So obviously with the One Big Beautiful Bill Act that was passed earlier this year, it provided for a 2.5% increase in the conversion factor for 2026. Which is obviously very effective, very important to our members. AUA has been really sort of deepening the inroads with influential staffers and members of Congress that are leading the charge on sort of a legislative reform to really help us not have to come in and fight for these conversion factor increases or prevent God forbid, conversion factor cuts every single year, right? By maybe tying some of the things that are tied with Medicare physician fee schedule to an inflation index, or eliminating some of that budget neutrality that tends to come along with the Medicare fee schedule, right? This is really the conversation I think that a lot of people are familiar with, that it's one pie essentially of funding that goes to all of the parts of Medicare. And if you affect the increase or the spending in one area, that affects or decreases spending in another area. So if we eliminate some of that budget neutrality requirements, then we can allow things to grow a little bit more naturally as the economy grows. But it also allows for other natural shifts to occur as the economy shifts naturally as well. So those are some of the things that we're looking for. Again, the AUA has been very, very large, very influential in that fight, working with some of our colleagues. Well, really, Dr. Edney, some of your colleagues, with doctors Neil Dunn and Dr. Greg Murphy, along with members of both the GOP dot caucus as well as the Democratic dot caucus, to really kind of make some of these Medicare physician fee schedule cuts a more of a permanent thing. I'd say right now our biggest concern is the cut to the efficiency adjustment, which is scheduled to go into effect, 2.5% cut to the relative value units for 2026 and beyond, which, if we go back to the top of my little spiel here, you would see is equal to the 2.5% increase that we got under the One Big Beautiful Bill Act. So it would essentially null out all of those efforts. So, we don't really want to take one step forward, one step back. We would like to continue just to take steps forward and forward and forward. So that's the next big fight that we're looking at, I would say, as far as the Medicare fee schedule is concerned. Shifting a little bit more within the practice of urology, Dr. Edney, obviously administrative burdens like prior auth and step therapy, they continue to frustrate practicing physicians. Can you talk a little bit about some of the progress we've made in reducing those, and maybe what we might see looking into 2026?
Sure, indeed. The whole issue of prior authorization has been top of the list. A lot of the surveys, federal surveys that come back from the membership, list that very high towards the top of the list of stressors for everyday practice. And we've heard that it's been a perennial ask at the summit. There's a federal bill, which now has more than 230 co-sponsors on the House side, which is enough to pass. And we believe that there are also enough co-sponsors on the Senate side to pass. The insurance industry, however, has pledged to make several reforms, and it's likely that Congress is going to wait and see what reforms can be made on their own on the insurance side before passing that bill. But we've through our advocacy work over the years, we've built up enough co-sponsorship likely to be able to get this bill through. So we're kind of waiting to see what the insurance industry comes with, but it's top of mind. It's something that our staff keeps an eye on all the time. Unfortunately, CMS has just announced what's called a WISER initiative, which is essentially prior authorization in standard Medicare, not even Medicare Advantage, standard old-fashioned Medicare. There's a model now that they're going to start implementing in 2026 for certain diagnoses to implement prior authorization in Medicare. That's bad news for us. We've commented, and we have a good relationship with CMS. We will continue to comment and let them know the inefficiencies and really poor care that results from prior authorization. So we'll keep a close eye on that as well. Josh, telehealth has become a vital tool in urology. How's the AUA working to ensure the continued access and reimbursement for these services?
Great question. I would say, in the short term, right, the AUA, like many in the House of Medicine, really pushed to make sure that meeting back channels, talking to congressional staff during the entirety of the government shutdown, right, the longest in U.S. history, to ensure that the CR, the continuing resolution that finally came together and reopened the government, extended the Medicare or telehealth extensions that have been in effect since COVID. And that extension does go through January 31st, which is when we'll have to see sort of another continuing resolution or some sort of permanent funding for the remainder of the fiscal year get through Congress. most likely we're going to see another CR that will carry us through either the middle of the year or possibly all the way up to September 31st or September 30th, which would be the end of the fiscal year. So I would imagine that these telehealth, payment flexibilities will continue to be in there. AUA led multiple community letters that were not just, and this is one of the things that does differentiate us between a lot of our sort of compadres within the medical specialty space. Our letters that we lead are not just physicians like yourself, Dr. Edney. We're not just speaking on behalf of them. We brought together and we bring together a patient advocacy sort of cohort of 50 to sometimes even 80 urologic specific patient groups, and a lot of them were a part of our our sort of pledge to the hill, our requests to the hill, showing that physicians and patients really want these extensions to go on and to continue. And they were a part of our letters, they were a part of our hill advocacy activities, and I think that really was one of the things to help drive the message home that it needed to be included in the CR. So that's really kind of the big thing there. Obviously, we continue to push for permanent extensions to telehealth, Medicare flexibilities and payments. So we'd like to see that become a permanent fixture within the Medicare system. And then, of course, usually private payers tend to follow suit afterwards, although some have already done that ahead of the game. But of course, most excitingly, and I think Dr. Edney, particularly for you, is the fact that the AUA under the Public Policy Council has launched a new committee focused specifically on technology issues like telehealth, AI, other emerging tech, to really sort of look at it as health policy is coming out, to not only have a comment on some of those policies that are coming out, but more importantly, to help be a leading voice in the crafting of those health policies with the Urology, Telehealth, and Technology Committee that has recently been launched.
Absolutely. I'm very excited about this committee. It had its inaugural meeting at our Health Policy Weekend that just passed. It's being led by Dr. James Stinson, who's fantastic, and it's populated by 12 of the absolute rock stars in urology across telehealth and artificial intelligence, folks who understand not only the technology, but the regulatory apparatus that's going to follow, and have tremendous influence on how we're able to use these tools, and also being able to advocate for the research we need to be doing in urology with respect to the application of all of these tools. So this is an absolutely fantastic committee. I'm very excited to see its work product as we go forward.
Well, Dr. Endine, as we switch gears a little bit here, one of our goals is ensuring the access of full range of treatment options for all patients. Can you talk a little bit how we're addressing some of the disparities in care-based practice, particularly on geography or financial statuses?
Sure. So speaking in terms of geography, we know from our census data that about 60% of counties in the United States lack a urologist. There just isn't one. And these tend to skew towards rural counties. And part of the reason we understand is that, residents graduating with enormous debt burdens from college and from medical school need to practice where they can believe that they can repay some of those debts. And working in rural areas sometimes is associated with slightly lower pay overall compared to urban and suburban environments. And so we know that's a challenge. And so we've worked with members of Congress to institute to advance the Specialty Physicians Advancing Rural Care Act, or the SPARK Act. This has been an ask for the last several summits, so people may be familiar if you've been to the summit. This provides loan reimbursement for specialists who agree to practice in rural areas for up to 6 years. And so this is a very nice and tight, it's a very good bill, and it's gained a lot of bipartisan support. So we'll continue to work for that. We have solicited endorsement from 40 other specialty societies in the push to get this bill over the finish line. So we've made a lot of progress, more work to do, but that's really how we're trying to address, in particular, rural health shortages. So pivoting a little bit here, Josh, to prostate cancer, it's a major focus. What's the AUA doing to advocate for PSA screenings and reforms to the USPSTF recommendations?
Yeah, so for those that are not familiar with the USPSTF, or the United States Preventive Services Task Force, right? It's a appointed government body made up of 16 volunteer members that tend to be nationally recognized in prevention and evidence-based medicine, but they all usually fall within primary care. There's not a lot of specialty input involved, particularly surgical or urologic input. So even though the AUA has tried multiple times to get members onto the USPSTF, we've not seen a whole lot of give from that perspective. Now, this is obviously important because while the recommendations that the USPSTF are putting out are supposed to go towards primary care physicians, they deal with the issues that urologists, oncologists, radiologists, other specialty physicians deal with on a daily basis, that they do the research in, that they are the ones that are going to be doing the major surgeries or treatments on. So it's important, at least in the AUA's perspective, that we be a part of the conversation. And especially since the letter grades that the USPSTF assigns to a recommendation affects whether or not it is to be reimbursed by Medicare or Medicaid, it's hugely important that urologists and other treating specialists are a part of that conversation, so that way we can properly guide the review of the science and give a clearer view as to what is actually happening from a clinical and daily experience when it comes to those procedures and those treatments. So, while USPSTF has consistently given PSA screening a low grade for many years, it got a D. Sometimes even, I think before that it was receiving an I. It recently received a C, I would say, I think back in 2016. You might have to check my math on that one, Dr. Edney, but that came with a lot of fight by the AUA, a lot of involvement, really kind of pushing to see a reform to the way that the USPSTF does their process, making it more in line, particularly since it affects reimbursement, in line with all of the other government agencies that have to put something out for public comment, right? That there's a formalized commenting process, that then they notify that to the public. The public at large is allowed to participate, and then not only participate, but then that the agency, or in this case, the task force, review those and then respond accordingly when making their recommendation. So that's the fight that the AUA has been doing for many, many years. And it's something that we've seen a lot of sort of growth and acceleration, but it can change depending on who is really chairing the USPSTF. So I think one of the things that is interesting under this new administration is that they are pushing for some of these more specific changes that the AUA has been looking to see, right? That there is specialty involvement in some form. They actually, HHS reached out to the AUA and asked us to nominate some members to be reviewed for sitting on the USPSTF. They gave no guarantee that any name the AUA puts forward would be on the task force, but the fact that HHS proactively reached out to us, I think, is a big step in the right direction for this fight that we've been doing, at least since I've been with the organization since 2012. I think also specifically kind of talking about the prostate cancer in and of itself, one of the other things that we've been pushing is the PSA Screening for Him Act, and that is standalone legislation that would allow coverage for PSA screening for men that have increased risk of developing prostate cancer. So either family history, genetic predisposition, such as being a Black or African American, other sort of genetic markers that might indicate that necessity. It would allow for them to be tested for prostate cancer with zero cost sharing. It would require that through all of the federal government agencies, that all of the federal pay-fors, all of those public pay-fors. And we've seen some success on that legislation. It's gained more and more popularity within Congress itself. But truthfully, Dr. Edney, where we've really gained the most ground is at the state level. We've passed similar or mirrored legislation and in nearly 15 states at this point that would require the same thing, no cost sharing for those at risk or increased risk patients. For the Medicaid or state similar Medicare system, Medi-Cal, if you're out in California, as well as depending on the state, because it can vary from state to state, the legislation that does get through, as well as a lot of the private payers are required. If they're going to operate within that state, they have to include PSA screening. So a lot of success that we've seen there at the state level, and a lot more success that we're gaining at the federal level on some of our issues to really move prostate cancer screening forward. Changing it up just a little bit here, Dr. Edney. Research funding, always another big battle for us. Can you talk a little bit about the current landscape of urologic research support and also how our members can help protect it?
Sure, absolutely. So as I mentioned before, there was a threat with the administration's original budget proposal to slash NIH funding. It appears we've avoided such a slash, so NIH is likely to remain whole. However, this most recent CR, which stands for continuing resolution, that's what Congress does when they don't want to pass regular appropriations. They just pass what they were spending before. The most recent CR got a lot of press because it led to the shutdown. There was actually a CR back in the spring, and as part of that CR, there was a call for a slash to what's called the CDMRP, Congressionally Directed Medical Research Program. And that's housed within the Department of Defense. And it's a huge center for funding research, federally funded research. In fact, it's second behind only NIH in terms of federally funded research for urology and a variety of different conditions. There are 30, within CDMRP, there are 35 different disease-specific centers, if you will, 4 of which are focused on urologic research. And 2 got called for very sharp reductions. The one for prostate cancer got cut to 35 million from 75 million. And in fact, kidney cancer, which stood at 50 billion, got zeroed out. They were going to zero out kidney cancer research. And that was obviously catastrophic for kidney cancer researchers. And so we have been working with coalition partners and our research advocacy team very hard on Capitol Hill to work with the appropriators to let them know what a disaster this would be actually for urologic research. And we've been working extremely hard to mitigate these cuts and to, in fact, try to reverse them. And I can report a little bit of good news here. In the House version of the bill, it actually restores kidney cancer research to a level of 15 million, not where it was, but it's something, which is good news. We don't have language yet in the Senate that mirrors that. We're hopeful that the Senate will come along and sort of match something to make kidney cancer funded again. And so we hold out hope for that. We continue to work very hard, and we're optimistic, hopefully, that by the end of this process, we will have retained some degree of significant kidney cancer funding research. It's just absolutely unthinkable that they would completely zero it out. So we're working hard on that. More to come on that. So those will be the next steps. What you can do to help out as a member. Couple different things. Be standing ready to participate in AUA activations. These usually come by way of email, and they're very easy ways for you. It's all set up for you, set up to contact your member of Congress to let them know that these are issues that are important to you. So look out for those emails and respond to them when you get them. And finally, if you are a researcher who has been affected by these proposed funding cuts or funding cuts that have in fact taken place, please send your story to the AUA. We are collecting vignettes of stories, real stories of real researchers who have been harmed by these cuts. Send your story to this email address, government relations, all one word, governmentrelations@auanet.org. governmentrelations@auanet.org. Write your story down. Please send it in. We're collecting them. And these are incredibly important as we go to Capitol Hill to be able to relay real-time stories from our members who are suffering now. And therefore their patients are suffering for this lack of critical research funding. So please let us know if you have stories. Josh, let's shift to state advocacy. What trends are we seeing at state level legislation that impacts urology?
Yeah, so as we look at the states across the country, and of course, this being an odd numbered year, all 50 states were in session. For those that are not aware, there are 3 states that every year they only meet every other year. So odd numbered years, all 50 states tend to be holding their session. Of course, these are breakneck speed sessions. Most of them are 3 months or less. with, usually by June, July timeframe, nearly all states are done, given a handful of states that meet year round. So looking at the trends that we saw across healthcare uh, within the 50 states, it really sort of fell into three sort of category buckets that we were looking at. And then there were a few different issues that would fall underneath those different category buckets. And the ones that came up the most were insurance requirement issues. So, prior authorization, step therapy, other forms of utilization review, access to treatments such as prostate cancer, biomarker testing, infertility, those sorts of things. Those all kind of fell under that insurance requirement bucket, and that was the largest bucket category that we did see across the 50 states, with over 66 bills introduced on those different categories of issues. Behind that was, what we kind of classify as medical business. So changes to certificate of needs for hospitals or ambulatory surgical centers, things like that. That was a big one. Restrictive covenants, a lot of legislation on, not necessarily legislation that passed, but a lot of introduced legislation on, eliminating restrictive covenants or restricting restrictive covenants within Medicare. Some information on Medicare liability, or changes to the non-economic damage caps. And then, of course, we're starting to see more and more AI in healthcare legislation get introduced, but states like the federal government, they're not exactly sure what to do with that just yet. So I think the launching of the UTTC is extremely important. And then, of course, the last sort of large group or large bucket area we saw dealt with medical licensure. And this one is a really kind of interesting one, Dr. Edney, right? While we saw certain things like allowing for out-of-state providers, that's something that has grown and grown with more interest from states to make it easier for out-of-state providers to provide in state, particularly since the pandemic. And of course, we're seeing more states now have already joined the Interstate Medical Licensure Compact. Well over 30 states are within that, so we're not seeing as many states introduce or pass that legislation, as we are kind of on the tail end or winding down effect of getting that passed across all 50 states. The interesting one is a new sort of effort to address the workforce shortage, and that's through an alternative pathway to licensure within an individual state. Dr. Edney, as you know, states are the ones that control medical licensure, and what you need to do to be able to legally be licensed to practice medicine within a given state. And states are trying some really different things to really solve the workforce gap by either allowing for international medical graduates, those that have been foreign trained and have not gone through a US-based residency program, to come in and be licensed to practice in their state without having to redo a residency program. We're seeing that really kind of get picked up quite substantially. And then the other one, a little more interesting, I think, is what's sort of known as the assistant physician or apprenticed physician model. It's got a few different names that kind of does just that. It allows somebody that does not go through residency to then train or apprentice under an already licensed and practicing physician within a state. And after so many years, depending on that state, that medical school graduate can then get a license to practice medicine, as most states that are introducing this legislation are doing it in a way that this is a sort of temporary to permanent licensure process. They're not doing this as a way to sort of serve as a bridge or gap while that medical school graduate looks to try to rematch within subsequent years. So that one's really interesting, because while medical licensure was the lowest out of our top three sort of categories, the alternative pathways to licensure itself was the number one issue we saw across the country this year, with 37 bills introduced across all 50 states. So, it's a tremendous thing that people are looking at. The IMG method is the thing that most states are looking at and most states are starting to pass. with the assistant physician or apprenticed physician model being much further behind, but it is gaining ground. States are passing it. States are considering it. So it's something that, we from the AUA, we really do have to think about, what do we consider, sort of the involvement of our organization, and, where do we want to come in on some of these issues. So very interesting times at the state. It's very important that when it comes to state advocacy, physicians are involved, that urologists are involved, and with that, we've been encouraging members to host lawmakers in their practice to really kind of understand how a urology practice is a pillar within the community. I know, Dr. Edney, you yourself have got a chance to do this. Can you talk a little bit about why this is effective, and of course, maybe give some advice to somebody that might want to do this themselves?
Sure, it's an extremely effective way to get your name on the radar screen of your state senator and your state delegate, it's a nice way to sort of build that relationship, and you can really very easily become the go-to healthcare person for your state senator or delegate. So once Josh stood up this program at the state level, I said, I'll go first, and I did, and I called Senator Mary Beth Carrozza, who's my state senator, and Delegate Carl Anderton, and I just picked a Thursday afternoon after hours. I said, come on over. I'm going to give you a tour and we're going to chat about healthcare. They were happy to do it. They showed up. We gave them a tour of the office, tour of the ambulatory surgery center, and then we sat and talked for about half an hour. We went over issues of the pressures of prior authorization in the state of Maryland, where that's where I live. And because they have very close relationships as legislatures with the insurance companies, because they see the insurance companies all the time come through their office as well. And so, they're able to kind of be a go-between, and bring our issues to the insurance companies. We talked about medical malpractice reform, sort of a quintessential state issue. Yes, it comes up at the federal level once in a while. Most of that activity really is at the state level. And it's usually trial lawyers keep going back to the trough, trying to raise things like caps on non-economic damages and other things that they keep trying to do. It's important for us to fight against, because it increases the cost of care unnecessarily, and lots of reasons to fight against that. Rural health challenges. I live in a rural part of the state, so there are certain challenges there, protecting telehealth protections, for example. But also, and we're seeing this now, is in certain states, certain states are getting involved in different independent practice models. There's sort of an assault going on with respect to independent practice, in particular, the notion of consolidation and practices joining together and under different types of models. Some states are kind of leaning heavily on putting the finger on the scale of what the state's going to consider acceptable or unacceptable for different types of independent practice business models. And so we're seeing an assault on independent practice. It's very important that we fight against that. And so those are some of the issues that go on. But I thought the meeting was extremely valuable. They learned a lot. And again, it keeps us on their radar screen. And both of them will now call me, when they have a question about, something in healthcare and they want a specialty voice or urology voice, they'll give me a call. And it's nice to be that go-to person. You can very easily do it. They're happy to come. And I will say, although, nothing was exchanged campaign-wise for that visit, it's also very helpful as you build these relationships with your state representatives. Go to their fundraisers, and make a contribution, just a personal contribution. And at the state level, it doesn't have to be a huge dollar amount. Give them $100 or a couple $100. You'll have a friend for life. They'll answer your phone calls. They'll put you on speed dial. But bring them a check to their campaign. It's not a quid pro quo. It's just hey, I appreciate our relationship. This is something for your campaign. I really appreciate that we can talk to each other about these issues. And that's what it is. Easy enough to do. And it gets you in the front door and it keeps you involved. So I highly recommend you establish and maintain those relationships with your state level lawmakers. That's been a great program. And so
it's amazing, really, just the way that one voice at the state level, the right expert voice at the right time, can make an effect. So definitely appreciate you sort of jumping in both feet first, on this program to get urologists bringing their elected officials to their practice.
Absolutely. And we're starting to wind down here. Josh, a final question: how can AUA members get more involved, whether it's attending state lobbying day or connecting with their section leaders?
Yeah, I would say the easiest way that you can get involved is really come to the AUA's website. You particularly go to the advocacy tab on that website. And, Dr. Edney, you mentioned it earlier. We've got action alerts. We've got an action center. If you're not currently getting the emails that come out over the different both federal and state sort of grassroots pushes that we're doing, sign up for that. That's going to be the quickest thing to get you involved. It's going to be the quickest thing to kind of get you tracking it. Advocacy in general, come to our summit. It's held every year in Washington, D.C. We'll bring you to the Hill. We teach you how to advocate. We give you those tools that you need to really be able to tell your story and your patient's story to your elected officials. And this is translatable to both the federal and state level. So what you learn in D.C., you can apply back home in your state capital. So it's very easy to do there. And then, of course, if you've got other questions, if you want to figure out other things to do, if you have an idea on something you'd like to try from an advocacy perspective, we're open to hearing that. Reach out to us, your government relations at AUANet.org. It's the same email Dr. Edney mentioned earlier. So please talk to us from that perspective. We really want to make sure that we're plugging you in, particularly if you've already got an existing relationship with your elected official. That's the thing. A lot of people don't realize is that, hey, just because you're neighbors with, somebody, that goes to your state capital or comes to the DC, we can help you leverage that relationship to make sure that urology gets the respected needs from our different elected officials. So those would be the things I would recommend. Yes, definitely. Well, thank you so much for tuning in to Capital Stream on AUANews Inside Tract. We hope this recap inspires you to stay engaged and advocate for the future of urology.
Advocacy is a team effort. Every voice matters. So let's keep the pressure on and the steam rising.
This has been an AUANews Inside Tract podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.